My name is Philip Saplinski, Jr., MD, and I'll be discussing the Part 3 and final of Secrets of the Trauma Chest X-ray when chest X-rays go bad. I wanted to begin by discussing pneumomediastinum. These are caused by tracheal or esophageal rupture or penetrating injury. We see these most common with blunt chest trauma. It is caused by an abrupt compression of a pulmonary parenchyma or increase in intraluminal pressure against a closed glottis. You can see this being similar to a Valsalva maneuver with a blunt chest trauma. These can be caused non-traumatically, also by individuals that lift very heavy objects, as in weightlifters or manual laborers, or individuals that put a lot of force into a large brass instrument. I also wanted to clear up whether or not a pneumomediastinum can cause a pneumothorax, or vice versa, if a pneumothorax can cause a pneumomediastinum. Essentially, air can move through a rupture of a mediastinal parietal pleura into the pleural space from a pneumomediastinum to a pneumothorax. However, the reverse typically cannot be true. A pneumothorax oftentimes cannot move into the mediastinum and cause a pneumomediastinum. Also, there's going to be a new sign that we'll discuss called the diaphragm sign, and then two things that we've already discussed previously with a pneumothorax that can come with a pneumomediastinum, which is a deep sulcus sign or a mediastinal shift. So the mediastinum, you will see air dissecting into the mediastinum. Here, you can see that air has dissected out the mediastinum, and you end up with what's called a continuous diaphragm sign. It's essentially a halo of air surrounding the heart. And across here, you can actually see a line that goes above the diaphragm, and typically you cannot see a differentiation between the heart and the diaphragm in most chest x-rays. And in this case, you can see this definitive line, and this is the diaphragm sign, and that will clue you into that there might be, in fact, a pneumomediastinum. Now, here's just another picture of it. You can see that air has dissected into the soft tissues around the left cardiac margin, and it continues up into the mediastinum here, and this, in fact, is a pneumomediastinum. So pneumopericardium, this is essentially air tracking around the heart here. You can see this on both sides. What makes this different than a pneumomediastinum? So you can see that this individual has a chest tube. They were being treated for recurrent pericardial effusions, and what you can see here is that the air is tracking up around the heart, however, doesn't go up in the mediastinum. Essentially, you don't see air around the reflection of the aorta and the main pulmonary artery, and that would be what differentiates a pneumopericardium from a pneumomediastinum, is that the air, in fact, does not travel up into the mediastinum here. Mediastinal hematoma. This becomes a little bit more obvious to see. You'll see mediastinal widening here. You'll see the shadow of the aortic knob is obscured by soft tissue density. And in fact, here, within the circle here, you can see what is likely bullet fragments within the heart. There was imaging that was done afterwards for this patient that showed that the CT actually showed a large mediastinal hematoma, and that's what was causing this mediastinal widening. Subcutaneous emphysema. This is something that oftentimes happens with placement of chest tubes. In fact, you can see a chest tube here placed. What happens is as you go through the chest wall, you'll have air leakage from the lung into the subcutaneous tissues and in between the muscle layers, and this in fact is air trapped within the muscle layers and the subcutaneous tissue, and this is called subcutaneous emphysema, and oftentimes happens with chest tubes and typically will resolve on its own. Aspiration of objects. This is very common with children. They will come in, they'll have difficulty breathing, or maybe mom saw them swallow something, and they bring them in, they get a chest x-ray, and you find something odd within the chest x-ray. This is a child, you can tell just because of the clavicles here, and the bone structure insinuates that it's a child. And in the right mainstem bronchus, it appears to be an object that's stuck within the lung. They got a lateral view, and in fact you can tell this is some sort of bobby pin or nail that the child aspirated into their lungs. Air trapping. Air trapping is essentially a ball valve effect of when the child or adult, as it were, takes a deep breath and there's an object trapped within the bronchus or in the lung, as they take a deep breath, air will work its way around the object. And then as they try to expire, the air will not move its way out. And each time they take a breath, the lung gets larger and larger, and it becomes, in this case, hypertransradiant, i.e. meaning blacker compared with the left-hand side. So you can see here that in fact this right-hand side is much darker than the patient's left-hand side. And one of the tricky parts is when people aspirate food, you won't see it on X-ray. It won't be dense enough in order to see comparative to the lungs and the bony structures above it. And in this case, the child had aspirated a peanut into the right bronchus, and it's not visible on this radiograph, and each time the patient would take a deep breath, air would work around the peanut. However, it couldn't work its way back out. Finally, every once in a while you see odd objects on a chest X-ray that you can't explain, or you're suspicious maybe they aspirated it, and oftentimes this would be the case to get a lateral chest X-ray also, to get a 3D visualization of what the thorax and chest wall looks like. In this case, we just took a picture of this individual and found these odd markings on the chest wall that looked metallic. One had a ball on it, one did not. And in fact, these were nipple piercings on a male patient, and apparently he has lost the ball to one of the rings here. But also too, you notice that there are leads, there are wires. Finally, pleural effusions. I wanted to talk a little bit about pleural effusions. We see this term a lot, but oftentimes we can't discern out what exactly is the pleural effusion. So the pleural space is a potential space, and we've mentioned several times now with pneumothorax, and air can get trapped within the pleural space. But what about fluid? So it is normal to have 2 to 5 cc's of fluid in the pleural space. It lubricates the lungs and allows the lungs to slide along the chest wall. And 2 to 5 cc's is normal. The body continually creates it and reabsorbs it. However, if you look here on the right-hand side of the patient, you see this blunting of the costophrenic angle, and then in a lateral chest X-ray, you can actually see what looks like fluid tracking in between the fissures and then blunting this angle here, and this is a pleural effusion. Diaphragmatic rupture. This is an unfortunate circumstance where an individual was in a car accident, and 6 days later this was noticed on a chest X-ray that the diaphragm itself is protruding into the thoracic cavity, or in fact has perforated, and now bowel contents are working up into the thorax, and this is a diaphragmatic rupture from increased abdominal pressure during this car accident. And finally, I just wanted to give you a complicated picture. I'll let you to look at this yourselves. However, I will note that you can have multiple objects in an image, and these can take some time to read, and I'll allow you to play with this one and find interesting aspects of it, but I'll point out some things that I noticed. There's a thorovent right here. There is a chest tube here and here, an endotracheal tube that is difficult to see but looks like it may not be in quite far enough. Then you have what is likely a central line going in, and then subcutaneous emphysema here. And then if you notice, the mediastinum has worked its way over to the patient's right-hand side, and it is very patchy on the left-hand side of the lung. So I would like you to take a look at this and see how difficult they can be to read, and find your own things. I can even see buttons here from the patient's gown, and see if you can find other things that I did not initially see. And that concludes my black, white, and gray secrets of the chest X-ray when chest X-rays go bad.